Oh, okay, okay. So today I'm gonna talk with you guys about the history taking and a physical examination. First of all, I want to introduce a little bit about myself. My name is Work, and I used to be a doctor in Vietnam, and right now I'm in America. And if during the time of the lecture, if you guys have any question, just let me know. Okay, just stop me and ask the question. And I don't know, for some reason I don't want to turn on the group chats because I cannot see the full slide. So just let me know and just turn on the microphone and tell me if you have any question. You guys can hearing? Do you guys can hear me well, or any problem with the technical issues or not?
Yeah, it's very clearly. Let's start.
Okay, okay. So today I'm gonna talk with you guys about the history taking and the physical examination. So based on the U.S. medical licensing examination, or USMLE, and for those who already have the opportunity to have the clerkship in the America, I already give the lecture about that, and we spent almost 5 days for only one lectures. But today because we are on the online platform, we cannot do the physical examination. We cannot do the history. We cannot practice together. But I will give you some big picture about that, and I hope you guys can use the material here when you talk with a patient, not only in the US but also in Vietnam as well. Okay, and uh, the next lecture I will talk with you about the how to approach the patient with a chest pain, with cough, with back pain, with abdominal pain, which is really common in the American. So now we go to the first slide. Oh, I don't know what's wrong with the. Oh no. Okay, here. So first of all, I want to share with you about the key messages when you approach the patient. Those are five key important things when you approach the patient. And um, I think that is the rule of the game. And because, in Vietnam and in the US, I believe there are still some differences between the Vietnamese patient and the US patient. But for some reason we still missing some points. So I think that we can use some rule when we approach the patient in Vietnam. And first of all, we ask for permission. We explain what you will do with the patient. And number three is really important because recently they are very strict in spoken English, especially in the exam. And a lot of people fail because of spoken English. They have the reason to do that, and as you can see here, speak slowly, clearly, and loudly. The reason why, because the medical error is really common in the US hospital. And one of the most common that causes the medical error is miscommunication. So to avoid or to reduce the risk of miscommunication, they recommend us to speak slowly, clearly, and loudly. Okay, and use short sentences and use simple terminology. For example, you are a doctor and you are in the patient room, and after you introduce yourself with the patient, and then you want to ask the patient chip complaint. So there's two ways that you can ask. So what do you think? Which one is better? Okay. Number one, how may I help you today, Mr. A? Number two, Um, my name is Dr. Bui, and I wonder if I may know the real meaningful, severe complaint that make you go to the hospital today, Mr. A? So which one is better?
The first one.
Yeah. So it's really important because the patient is really stressful enough to be in the hospital. So use the short sentences as much as you can, and the patient can catch the idea from you guys, and they can understand and they can communicate effectively with the doctor. Use simple terminology is really important. For example, after we do the history and physical examination, we give some initial idea about what is going on with the patient's conditions. We tell the patient that, Mr. A, you have something called myocardial infarction. The patient may say, "What the heck are you talking about, doctor? What does that mean?" So the patient may not familiar with the medical term. Instead, I would recommend you guys use the very simple terminology. You can use like heart attack, which is better than the the term myocardial infarction. Okay. So for 5 point here, that is the key. That is the rule of the game. Okay. And for those who don't have the opportunity to have the clerkship in America, so this is the picture of the typical examination room in the US. As you can see here, this is the patient bed, and a doctor sit here, and a doctor sitting face to face directly with the patient and talk and obtain the history. And as you can see here, this is the computer, because right now in the US, most of the hospital, they are trying to replace all the um, traditional record by the electronic records. So that's why we use the computer in the examination room. And I would divide the entire story into 3 parts: the introduction, the history and physical examination, or AKA, or also known as the H&P. And in the US, you will hear the word H&P all the time, which means history and physical examination. Okay. And the third part is closing. For the introduction, we have 1, 2, 3, 4, and 5 part here. And that is the template that you can use. I just want to highlight some point here in this slide. So my question here, why do we have to wait 3 or 4 seconds here? If anybody can know the answer, just let me know.
We wait for the people inside to answer that they are free or not, so we can come in. Sometimes they are busy doing they sell stuff that we can come in, like changing their clothes or something.
Correct. Yeah, they might be changing the clothes at a time, and they don't want anyone to enter the room at a time, right? Okay, so after that, you say hello to the patient, and if you're a doctor, you can say, "I'm Dr. Bui," and if you're a medical student, you can say, "I'm a 3rd year, I'm the 4th year medical student." And offering handshake, why do I put it? Be careful here, because for some reason that because sometimes you may have the patient who have the left side or the right side weakness, and the patient cannot shake hand, right? So be careful. If you notice that the patient may have the weakness, don't offer the handshake. Okay. Or you can use another hand. Okay. And remember the first rule: ask for permission. Is that okay? Okay. And then you go to the first question. It means like you ask the chief complaint of the patient, and then go on with the entire day history. For the closing part, we have some points here. After we finish the history and physical examination, we say thank to the patient. And the next three part here, we summarize all the information that we just obtained from the patient. Why we have to do that? Because for some reason we may collect the wrong information, and at the time the patient will hear all the story and they may correct you, and that is really good, right? So at that time you have one more opportunity to correct the information, and it will help you to reduce the risk of miscommunication. So that's why we have to put the summarizing part here. And after that, we do something called we give the patient the initial picture, what is going on with the patient condition. Because, we just based on the history and the physical examination at the time. So we cannot give 100% accurate differential diagnosis. You may give the wrong or the right diagnosis. It's okay, and we still have the lab test. We still have the imaging to confirm the diagnosis later on. So, but the patient need to know what is going on. At least the big picture, what is going on with the patient condition, and remember the last rule: avoid the medical terminology. If you have to use that, give them a brief explanation. For example, you may have something called heart attack, or sorry, you may have something called myocardial infarction, or we usually call heart attack. That's the good one we can use, okay? And remember the second rule: explain everything you want to do with the patient. So that's why we have the part planning here. To confirm the diagnosis, we need to do something, blah, 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 or you may need to do the x-ray, or you may need to do the EKG. And if you have to use something, more, some medical terminology, make sure that you explain to the patient. For example, if you want to diagnose the osteoporosis, we have to do the DEXA scan, and the patient may not understand what DEXA scan is. We can give a brief explanation after that, okay? Counseling is really important. I know that in Vietnam we don't have time to counsel the patient, but we have at least 4 or 5 minutes. Here in the US, we can counsel the patient. For example, if the patient has the hypertension, we can counsel. We recommend them to follow the diet with low salt, low cholesterol, and the final part here is we give them the opportunity, if they have any question or not, they can ask you and you answer the question, okay? And then say goodbye. That is closing. And now for the rest of the lecture, we will focus on the history taking and the physical examination. This is the mnemonic that you can use, or you can use any mnemonic that works for you. You can, search online, you can Google it, and I prefer this one. Okay, it's up to you guys. Okay, I use because it's pretty familiar with liquors, which is alcohol. And for the chip complaint of the patient, we ask those all the characteristics of the chip complaint. Okay, location, intensity, quantity, quality, onset, radiation, aggravating. And for the past history, we have past medical history, allergy, medications, family history, or OBGYN, social and sexual history. And the third part here is review of system. Okay, we have to go all the part here in the history taking. For example, the patient come to the hospital because of chest pain. We can ask the patient, where does it hurt? All those template here you can use when you talk with a patient. What do I mean by based on the differential diagnosis? I just want to highlight here associated symptoms. For example, when the patient has the chest pain, what do you think in the differential diagnosis when the patient has the chest pain? What do you think?
Myocardial infarction,
Okay.
pulmonary embolism, maybe from the musculoskeletal, not
Right.
only in the heart, maybe from the GI.
Okay. So as you can see, the patient has the chest pain. You can think of some of the causes from the heart, causes from the lungs, causes from the GI, from the musculoskeletal. So based on differential diagnosis means like, for example, we think like the patient may have the problem with the lungs issues. We can ask, do you have any cough, any shortness of breath, any sputum when you cough or not? And if you think that the patient may have the problem with the GI, you can ask like any nausea, any vomiting, any abdominal pain. So associated symptom, there's no formula, just based on the differential diagnosis only. Okay. And for the past history, we will discuss the past medical history and OBGYN in the next slide. And for the allergies, we have some template here, and this is mnemonic that you can use to ask the patient when we review system by system. Okay, and for the social history, be careful with the sexual history because that is the sensitive history, that the sensitive information that the patient may not share with you. And remember rule number 1, ask for permission. So you can say like, now I'm gonna ask you some question about your sexual history. Is that okay? If the patient feel comfortable to share with you, go ahead. Okay. If the patient don't feel comfortable with that, you cannot, rush them, or you cannot ask them to uh, tell you about the history of the sexual history, because they in the US they have the right to refuse the question. Okay. For the past history, we have 4 components here. Have you ever been hospitalized before? Any medical conditions, and trauma, injury, and a surgery before? And remember, I don't know why, but in when I have a time to have a clerkship with the medical student from Vietnam here in the US, and they usually use the word, and do you have any disease? I I Disease is is not the wrong word, but for some reason the patient may misunderstand that word, and they may think that disease is infectious disease or contagious disease, and they don't want to share with you guys about that. Okay, so the better word is medical conditions or medical issues. Okay. And the OB/GYN, we have 2 parts here, OB and GYN. The first 5 part is GYN, and the first 2 part is OB. And this slide is the way we document the OB/GYN history, because in OB/GYN they have a special coding how to document the OB/GYN history. So my question here is, what is the difference between number of times pregnant and number of live birth? Anyone?
So you may get pregnant, but
you don't deliver the baby successfully? So that's a difference?
Yeah, for some reason they may have the miscarriage or abortion during the pregnancy time, and they may not end up the successful pregnancy. You got it? So
Yes.
for I just give some example here so you can understand more. Okay. And for this physical examination, we basically we go from head to toe. The patient, we have heme here, we have the abdomen, chest, cardiovascular, and neural part. And I'm pretty sure that we don't have enough time to go from head to toe for all patients because we have so many patients even in the US. And basically in the reality, we just focus on the part that you think this part is relevant to the chief complaint of the patient. For example, the patient has a chest pain. Of course, we have to focus on the chest and the CV exam or cardiovascular exam. If the patient had a headache, we focus on the neural part, okay? HIN stand for head, ear, eye, nose, and throat, okay? And be careful with the order in the abdomen and in the chest. Pretty different here. For example, in the as you can see here in the abdomen, we can see the inspection. We do the inspection first. We do the auscultation, percussion, and then palpation. But in the chest, we do the inspection first, and then palpation, percussion, and auscultation. Okay, different. And I want you guys to follow that order because it's really important. For example, if for some reason the patient has the history of atherosclerosis and the patient has the AAA or aortic abdominal aneurysm or ballooning of the abdominal aorta, and of course the patient has the risk of rupture, right? And the reason why we have to do the auscultation because we can hear some murmur, can hear some bruise, and we may think that the patient have the AAA. So if we percuss the patient, we give them the risk of rupture, and the patient may die because of rupture, bleeding, and hypovolemic shock, right? So be careful with the order when you guys doing the abdomen and the chest exam. And this is the heme part. I just go part by part here, and this is a template that I can give you guys to talk with the patient when you do the heme part. This is the picture of the ophthalmoscope and the otoscope here. And because we're on the platform, online platform, we cannot do the physical exams for you guys. I'm so sorry about that. But I attached the link of the video here. You can watch later. The same thing with the abdomen. This is the way we can do, and when we talk with the patient, we can use some template here. And this is the video that you can watch later about the abdominal examination. I will highlight some, whenever I need to highlight some key point, I will stop and, focus more, okay? And same thing with the chest. Okay, here is the video, is the link of the video you can watch. The same thing with the CV exam. But the CV exam is pretty different, okay? So as you can see here, the auscultation, the pulse, we check the pulse, the auscultation of the heart as well. And we repeat the CV exam in two positions. First, when the patient sit up, and when the patient lying at the head 45 elevation, 45 angle elevation, okay? And this is the link that you can watch how to do the CV exam. For the neural, the mental status part, we have 4 parts here: the orientation, the memory. In the memory, we have short-term memory and we have long-term memory. And for the attention and concentration language, And for some reason, for example, when you are in the exam room and you don't have time to go all the part of the mental status, and you have to choose the most important part of the mental status, go with the orientation. Okay, so 3 part in the orientation: person, place, and time. After you ask all those 3 questions here, you can decide whether the patient have a problem with the mental status or not. For the neural part, we the next part is the cranial nerve. We learn how to do the examination of the cranial nerve. This is a video. This is a link that you can watch how to do the cranial nerve examination. And just have a quick recall for you guys. I think you guys already learned the neuroanatomy with Dr. Talarico about the you know the the 3 branches of the cranial nerve number 5, right? You guys already learned that. So this is the distribution of the V1, V2, and V3. In the hospital here in the US, you will hear that the doctor don't use the word 5-1, 5-2, or 5-3. They usually say just V1, V2, and V3. Okay. So what is the name of the cranial nerve number 5? Just a quick recall for you guys.
Trigeminal.
Good. I already give you the hint here. Trigeminal, 5 branches. Sorry, 3 branches. 3 means tri, right? For bi means 2. For the motor, we check the muscle strength of patient. Just a quick recall. After we finish the motor examination, we have to grade the muscle strength of patient, whether the patient has the grade 0 or grade 1 or grade 5 muscle strength. That's the table for you guys to review. And the sensation, we have something called a Q-tip. We can, as you can see in the picture, we have 2 ends, the sharp end and the dull end. We touch to the patient's skin and we check the sensation. And remember, always check both sides of the patient, not just the defect side. Okay. We check the both side and we compare side by side, area by area. And the same thing with the neural reflex here. We have the hammer. We use the hammer to tap on the reflex area. We tap on the tendon of the patient and check check the reflex. And this is a table that you can review after. The same thing with the similar with the motor strength. After we finish the motor exam and after we finish the reflex, we need to rate the DTR the patient. DTR means deep tendon reflex. Okay, and this is 4 common reflexes that we can use. We usually check on the patient: tricep, bicep. Of course, we remember the rule for we have to check both sides, not just only one side of the patient. Tricep here, bicep, patellar or knee, and Achilles. And for the cerebellar exam, we have 3 parts: gait, finger to nose, and heel to shin. This is template that we can tell with the patient when we do the cerebellar exam. We can ask them to walk a few steps to see if they have any problem with walking or not, and finger to nose and heel to shin. And those are the links that you can watch when you can watch if I'm sorry, those are the link you can watch later about the neuro exam. I posted here, and you can watch later on. all those part of the neural exam, including, you know, the motor exam, the sensation, the cerebellar, those in 3 links here. Okay. And that's it. You guys any question? So this today the lecture is just only the general, you know, picture, and the next lecture we will focus on, you know, on some particular topic, like how to approach the patient with a chest pain, how to approach the patient with the abdominal pain or cough or shortness of breath. And basically we will, based on the information that, based on the knowledge that we learned today. For example, if the patient come in because of chest pain, we have to ask those two things here, and we learn something more here for the chest pain. Okay. Okay, that's all for the lectures about the history and physical examination. You guys have any question?
Can you tell us more about the CS test of the step 2?
Can you speak louder?
I was asking about the CS test because I don't know how it's really happened in the real test, and how to like how you manage time to ask the question to the patient, and how you can write about the note for the patient.
Okay. Okay, so in the real exam, step 2 CS in the US, they will have they will give they will give they will give you about 15 minutes for history taking and the physical examination, and another 10 minutes for typing. We don't write down, we don't write the patient note, we type the patient note. Okay, for some reason, because for example, I know some of the cases when we are in the exam room and for some reason the computer system scratched down and we have no choice at the time, so we have to write down, but it's rarely happen. So basically after the history and I would say H&P, okay? So after the H&P, we have another 10 minutes to finish the patient note. I mean, typing the patient note. And for the 15 minutes, we usually spend, because the history taking is really important recently, because they want to test you how to communicate with the patient, how to uh, speak with the patient, and how to build a relationship with the patient during the 15 minutes. So I that's so the good strategy to get the good score in step 2 CS is spend about, you know, about 9 or 10 minutes for the history taking, and 5 minutes for the 5 6 minutes for the physical examination. And of course the you know the key point to get the high score in the step 2 CS is just three key things that we can maximize the score in the step 2 CS is practice, practice, and practice. So the more you practice, the more you will be confident when you approach the patient in the examination room.
So what if you make the wrong diagnosis of the patient at the CS step, at the CS test step, and can your diagnosis related to your score?
Yes, the diagnosis. They have three different part in the step 2 CS to test every candidate. The first is of course, the spoken English. Okay. Second, they call CIS or communication and interpersonal skill. And the third part is integrated skill. It means like how you integrate all the knowledge that you learn from the textbook, you learn from the medical school in the reality or when you approach the patient. And they will check um, when you type the patient note, it means like they will know that the examiner will know that whether you obtain those most important information or not. And they also test you how um, um, how you obtain the information when you approach. For example, if you are in the patient room and you don't ask all those. For example, the patient has a chest pain and you forgot to ask the location of the chest pain. But when you are in the patient note, you are typing the patient has the chest pain on the right side and the left side. It means like you have a red flag in your patient note. It means you're not honest. Okay. And you make up the patient history. That's the really bad mistake. They will compare all the information when you're talking. Basically, in the room, they will have the mirror, one side mirror. So means like you can see just a normal mirror. But the other side of the mirror is the examiner who can look at you when you talk with a patient, and all they know that all the information you ask with the patient, and they will compare with the patient note. That is the way they test the integrated skill. And of course, for example, I just mentioned the lecture for the closing, we can give some differential diagnosis. And of course, we cannot give 100% accurate diagnosis because at the time we don't have the lab test, we don't have the imaging. So how can we do the correct answer for the patient? So we can give the wrong answer. It's okay, but it should be make sense. Okay. For example, if the patient has the chest pain, but you say the patient have the migraine headache, is totally wrong. It's totally irrelevant to the patient chip complaint. So if at least you give some initial idea, but it should be relevant to the patient chip complaint. For example, the patient has a chest pain, you can put the myocardial infarction, you can put a pneumonia, of course, based on the information of the characteristic, like the patient had a cough as well, patient has the fever as well, you can put the pneumonia in the differential diagnosis. But if you say you put, the patient has the appendicitis, it's totally wrong, right? Okay, so do you have any concern?
So do you do the physical exam for the patient in the CS that do you have to really do it like uh, doing some neural exam and if the patient have that problem but the people that they affect patient okay they cannot do that so how can we know that the patient have the problem.
Can you speak louder? I cannot hear you well.
Um, I'm asking about so in the CS test, if we if the case that they have some side that the patient, like we do the physical exam on the patient, and because it's a test, so that the people will fake the patient, right? So like so how so if there is a sign that they're key for the patient, but the fake patient cannot show it for us, so how can we?
You don't have to. Oh, I see. I see your point. So you mean like for some reason the patient may have the problem that they cannot fake it, right? For example, if the patient
Yeah.
has let's see. Wait. Let's see. For example, the patient has the cranial nerve 7 palsy. For example, patient absolutely have the paralysis in the half left or half right of the face. They cannot make it. They cannot fake it, right? Don't worry about that. They will choose the case that the real person or the patient, or they say the standardized patient or SB. The SB can fake it. Don't worry about that. And they're really good at doing that. Don't worry. Okay. For example, I got a case. Um, I got a case, and they do it really clear, and you have no way to ignore that. If you ignore that, it's your fault. Okay. For example, the abdominal pain, they can even a light touch. They will yell at you, and they say it's really painful. So they know how to make it really clear, because it's in the exam room, and they just want to do everything really clear for examination, for the testing purpose. So you don't have to worry about that issues. They're professional and they know how to do that.
Excuse me, can I share my screen about the information of class today?
Okay.
Okay, thank you.
And I have one more question. You told us that be careful when ask the patient to shake hand, right? So should we ask the patient for the shake hand because we don't know if the patient have the left side weakness or the right side weakness? So how can we do it like decently?
Oh, okay. That is the differences in the facility in America and in in Vietnam. So basically, when we before we enter the room, we have to knock the door, and in front of and on the door they have the patient chart, and they usually put the chip implant on the patient. And the way we usually do is we usually review the patient chart, the patient, before we enter the room. So that's why we have some initial picture of the patient before we see the patient. So and another way is you can clearly see the patient have absolutely. You can see the patient have the weakness in the face, and they have some problem with speaking. So you can guess. Okay. Or just simply, if you for some reason you offer the handshake, they cannot do that, and just say sorry. Okay. Because you don't mean to do that, right?
Okay.
Any question, guys? Oh, I got a chat here. I'm sorry, I cannot see the chat from the beginning. So can you send us the slide link? So you guys have any link from the group, or any link or sorry, I mean any email address of the class, so I can send it to you about the lectures. Oh, I saw some. Oh, I don't see. For patient to be where for patients nicer when you not enter. Okay, lung disease. Okay, could you please send us the link here? I don't know how to send. You mean the slide, the PowerPoint, right? So, do you guys have any email address of the group or any platform that can upload on it?
Could could you send the email from me, and I will upload on the Google Drive for all students.
Oh, okay.
Okay.
Okay, this is my email. We still have 5 minutes. Do you have any question? Okay, if you don't have any question, just send. If you have any question later on, just send me the email. I already put the email here, so for you guys can use that. Okay. Thank you for attending, and see you next lecture.